Okay, Dr. Sharma, I can see you.
Okay, let's go. We keep the atherectomy theme today. Okay, now this is the case number 11. 71-year-old patient has a class 2 symptoms despite medical therapy, has a PCI of the RCA, and has a positive stress, a significant apical, anterolateral, and lateral wall ischemia with near normal ejection fraction. As you see, patient has been a good medical therapy, and why it is ischemia, see here. The good LV, little bit of anterolateral maybe, and this is the right coronary, has a stent. How long ago?
November 2018.
Yeah, it was last year. Lot of distal disease. This is a typical patient with a diabetes and a PAD. So those patients will especially have the, and even right was very difficult, was calcified. We did rota stent and did fine. And now you see here the stent in the circumflex, which is fine. There is a moderate disease before the ramus. Ramus and or OM have the stents there already, which looks good. And then question is what to do with this diffusely diseased LAD. And this is the LAD. And there is always a little ulcer in the distal left main. We'll do the IVUS in the end to see what that is. You see the little distal at 12 o'clock position. But look at the diffusely diseased LAD now. You say, well, maybe it's a very small vessel. But look at the apex. It's a almost 2.5 millimeter vessel. So although it looks like 1.5, but clearly, and there are a few branches happening, and the calcium point of view, I would call it a moderate calcium, not a severe calcium, which is the tram tract. So what is the purpose? What do you want to do any atherectomy in these kind of cases? Well, I would say the one of the reason would be the patient has multiple branches. We want to have a less plaque shift. Secondly, you make an IVUS guided short stenting. You don't put a stent from there to there. You know that very high restenosis. So idea would be do the rotational atherectomy, dilate with a 2.25/30 balloon, and then to the IVUS, some area of the tightness, you stent, and then the remaining you confirm by the IVUS that does not need, there is a reasonable lumen of at least 2.5 or 3 millimeters square, so can be left alone. So that will be the goal, and you can have a discussion while we are finishing this case.
So, Samin, how far down do you think you're going to go with the rotoblader?
We go all the way to the distal lesion.
All the way to distal lesion?
Yeah.
Do you have enough to traverse there on the rotoblader, or you have to reload?
We'll go with the Dynaglide. So this is that very slow advancement.
So it says
Yeah, this is the one.
key here will be with this severely diffuse kind of small lumen, very small lumen. The issue here is perforation,
Yeah.
either during the rota or when you deploy the stent.
Yeah.
So
And
how
that
are
is
you-
why, very simple, low speed, small bar, 1.25, and get ready your balloon. In case anything happens, you have everything ready on the table, side by side, and you close that. So biggest concern here is the perforation. Absolutely. So you have the Joe stent, and now Papyrus, another stent, which is a single layer, much easily deliverable, but we actually have it. We haven't used it yet, but clearly the Joe, our classical Joe stent, in the area where the perforation will occur will be reasonable. So now the proximal mid-LAD segment was no problem. It is, this is actually,
So this is a 125 burr?
it's a 125 bar, and we're just trying to do, so this is the mid segment. Now question will be the distal.
Absolutely.
Yeah, this is the one.
You know, I guess
Same.
one of the concerns is in diabetics, do you just try to target the mid portion, just do that, stent that, see how it heals, see how they do symptomatically. You can always bring them back instead of trying to do the entire vessel itself, because for me, with this size vessel and diabetes, my thing is restenosis.
But look, the question is yes, and that is
In
one of the
between the
purpose
two
will be.
diagonals.
But look at that. The apex is also very tight. Even if we do it there, are we doing enough work? But let's see. We'll do a lot of balloon dilatation.
And just for completeness, this was evaluated by a surgeon?
Yep. And then this patient was last time. And because of the diffuse disease vessels, because even the RCA, they was not a good target.
Yes, we saw that, the outflow.
Yeah.
I guess it would be hard to do a limited lima and find the target spot in such
Yeah.
diffuse disease.
You know, what it will be done is to just bypass the apex. I have a few cases like that,
Good.
and those bypasses in these two cases have worked properly. But
And
it's
we
very
are going to
difficult.
show that now. You see this? We could not get the burr further down. So now we are going to go manually on the Dynaglide. We bring the advancer knob tight here, brake release, and Asad will going to pull the wire while I'm going to go on the Dynaglide. Go. Good. Fine.
Nice.
That's the point I was trying to make. You're going to have more than you could travel over that 9-centimeter segment on your rotoblader.
Yeah.
Got to gain some more purchase.
The problem is where do you stop? Because,
there.
Yeah.
I mean, we don't like, I mean, in Europe you have the drug-coated balloons. That would
I
be an
was
ideal
thinking
case.
exactly the same. I mean,
Or
when there
drug-coated
were
balloon.
BVS available, this would have been a BVS case, you know.
Or BVS. But
Yeah.
here, I mean, I can tell you, you place standing all the way to the apex, then
Yeah.
they come to me for radiation in 6 months. And
So-
there's very
so-
little that we can do.
The
Or-
resistance of the lesion was not that bad, huh, Sharma?
Yes.
The apical, the distal resistance, that's where things get thin, when the rota don't want to go, and then you think about the extra support. But in this case, it looked like a soft lesion, huh?
Yes, it was kind of a softer lesion, and the mid LAD didn't give any trouble. It was the distal LAD which had gave us a little trouble, but we were able to go through it. And now see here. Good. So we'll put a wire side by side and dilate with the balloon. And actually the good case, which is ready, they're getting ready, the CTO in room 2. As soon as they're ready, here is very simple case. We are going to just do a balloon dilatation, and area which does not get very good expansion, which we'll know, we'll put a stent, and then we do the IVUS. Because idea there is, and of course, look into this, the healed left main ulcerated dissection, and I'm actually have a very low threshold of wiring the side branches while you are stenting.
SS, can you do a OCT on that left main? I think that might be even more interesting.
That could be possibility also, yes.
But you're going to fix that ulcerated plaque, right?
Yeah,
No, actually, you know what? Very interesting. This plaque was there in the last year, the 2 angiograms, exactly the same way.
So the question is if it's only ulcerated or there is also stenosis there. And it's
Yeah.
very hard to...
Yeah, you're right. Look at this. If you want to review that here, see, there doesn't use, you don't see at all.
Nothing.
There is almost no left main disease. Now you go to this view, then you see that ulcer.
Yeah, I think that I would like to use here intravascular imaging to
Yep.
get confirmation.
Yeah, we'll getting the IVUS ready here, yes.
Some people will say we want to do FFR, but because you have an ulcerated, I would feel more comfortable if this is being fixed.
Yeah, that's a good point.
Go
It
6,
doesn't
8.
look to be obstructive, so the question is if
8,
stenting will
10,
change
12.
events there.
And that can improve also the vasoreactivity of the vessel downstream if you have a stenosis proximal.
Yes.
The other thing is the speed when you inflate the balloon. Many people go right to 16 atmospheres quick in these vessels, and the next time you see is blood in the pericardium. So I
12, 14. What I do basically, when you try to get a good balloon result, go to your whatever atmosphere you want,
Yep.
and then you crack the plaque, then go to half of it. Now go up again here.
Yeah, especially when you deploy the stent is when you
Yeah.
have to be careful. But
Yeah, now here. So now we are 12. Now go down to 6. So purpose there is that you crack the plaque, and now with a moderate pressure, you are taking it up. Negative. So those what we used to do in the era of the balloon angioplasty, hands guy. Yeah. And clearly we used to do oscillation also. There was a trial done, crack trial. That you oscillate your indeflator to have a better results. Long inflation also has been shown to be a better result with the PTCA. Okay.
looking
So,
good.
so far so
Careful
good.
The guide. Right, the guide's almost-
Pedro,
Yeah.
two comments for you.
Yes.
Yes.
First of all, I've done, next week we are coming to 100 cases I've done in our webcast here.
Yep.
I have never even seen a patient with the ejection fraction of 53% and a Syntax score of 9. How exactly did this patient reach Mount Sinai? That's one. And
No,
secondly,
but this
look,
is the third. Just want to say third is top.
Right.
Patient has the RCA, 2 branches of the circ, and this is the last leg of the diffuse disease. You're right.
So the second comment is only just because we've been watching either rotational or orbital since morning. Almost 2 decades ago, a case like this used to be a 5-minute single pass with the laser catheter, just because it is mild to moderate calcification, straight, long segment of diffuse disease, 1 pass and you were done. Now,
Nothing-
again, that's not fashionable or something which we use today, but I thought in a day we've been having all sorts of rotational ablation. Maybe good to remember technology works
Yes.
for that too.
All right. So we do the stent in the middle, and we can put a 2.530, which was supposed to be synergy, Giants. What was the other vessel?
Science.
Yeah, 2.533. Let's put in the middle only, and then we'll see, and hopefully they'll be ready by that time. Yeah.
So why?
What do you have? 33, 38, whatever.
38.
Yeah. 38.
So you're gonna leave that distal segment?
That's
no-
it. So what John said, John Fox, that leave the distal to the good balloon angioplasty, maybe it will remain fine. Go to the rota PTCA. Yeah.
Or DCB.
And no, yeah. Or
Okay, we
if
buy
once we
that.
get. Yeah.
What about the case number 12? Is there any news from the room? Or this will be Dr. Kinney?
Yes. That's the last one left with a total occlusion patient, so that we complete all the cycles. And that also is very calcified. So today what the symposium was complex coronary cases done by atherectomy, 100%.
Actually, we're doing pretty good with time. We
Little
have
bit.
still 30 minutes for our
Yeah.
discussion, so
Yep.
You stole our break.
yeah, that's true.
The break on the boat. I said break on the boat. And now I can tell you, there was a lot of discussion happened with the wiggle wire. I personally, I don't think anybody does more complex cases because of my personal referral, 1,500 cases. Of them, 800 comes from outside, not even Mount Sinai system. Refer to me complexity. I did the obituary on the wiggle wire 5 years ago and doesn't need. Because of your atherectomy with the guideliner and so, wiggle wire very complex, not needed. In the past used to be 2 atmosphere now. Because now we have so good with the terms of the guideliner has done so well, and both Godzilla and guideliner in these cases negative. So therefore wiggle wire at one point was very good device, but because of complexity you have to put another wire, then put over the wire system. Very rarely you can advance the wiggle wire directly. Okay, let's see here.
So-
All right.
So, Dr. Sharma, can
Yeah.
you do me a favor and
Yes.
fix this
Yeah.
nasty lesion in the left main? It looks
Yeah.
like to me, it's
Good.
it's an
OCT.
eccentric
Quickly.
lesion.
Yeah, right here.
We want OCT, SS. You want to do
Well, right
IVUS?
now, IVUS is ready, please.
Yeah.
Come on.
Listen.
It really looks eccentric and
Yeah,
nasty.
we'll do it, yeah.
Pull your wire back to
I mean, yeah, we'll pull the wire, and then key is that, one imaging is a little too much for Sharma, as you know. So don't ask me to.
Tell me the
Yeah.
story of this, the story of this lesion up there, that imaging filling defect. Is that from the beginning, the
Yeah,
first time?
always.
you-
No, not at the earlier angiogram.
Earlier angiogram, there's
Yeah,
from the
this-
beginning. So it
this-
has to
this
be
is
an
dissection. Yeah.
ulcerated plaque that.
Yeah, it might have happened, but it was there right from the beginning.
Yeah,
Good.
from
Good. Fine. Okay,
the
low mag.
last year's angiogram.
Low mag. So first we do just the short one low mag again. Yeah. So do the proximal segment, the left main again, because I may not have any time to show you the entire vessel, because it will take quite a bit unless we have a 2 millimeter per second withdrawal, but it's 1. Yeah. Okay, let's start from here. So that with the Ran wanted to
be-
know what that is, we will show. Okay, I was on the main screen, please.
Okay, good. We have it.
Okay, so meanwhile,
No.
you can see how well opposed you did the stents in the mid segment.
No, but it's,
We
I
need it
was
in
on the main screen.
Main screen, yeah. So this is the issue about these ulcerated plaques that the lipid core has been disappearing. So what you have is a crater there. It's like an ulcer.
Yeah.
And that's the difference between the ruptured plaques in humans in vivo, you always see that, versus the ruptured plaques in humans post-mortem, when you have the lipid core there and the clot on top. It's very interesting how survivors of acute coronary
Right around
STEMIs,
here.
you have that ulcer there.
There is a plaque there, right?
Yeah,
I
you
think
can,
li-
you can look at the MLA
Yeah,
there.
yeah.
the
Quite
stenotic.
significant. Yeah, I think it's a stenotic, clearly stenotic, yes.
Yeah, right there.
I ask you to fix it.
Okay. I think I can tell you, looking at it more and more, since we have done such a good job for the LAD with the one stent, if we allow 2 stents per patient, I think it will be reasonable to do it now.
Thank you.
Save 1 stent for other, yeah.
How can you say no to wrong Waxman?
So,
Direct
Pedro,
stent.
you did a lot of
15.
lipid pool and nears on lesions like that probably as well. What did you see there in terms of LCBI, and what's your take? You're an expert on vulnerable plaque. Is this a vulnerable plaque or not vulnerable?
Well, I think when you have these craters, which was that Rio Fold described when he said there was 5 rupture plaques per patient, these craters are harmless. The fact of the matter is the rupture plaque is a problem because it's thrombogenic.
Are they ready?
But if the thrombogenicity is out of the plaque, and what you have is a crater, that is, for me, is harmless. Most importantly, when you do ACS, STEMI, OCT, you see these, and the stenosis is about 3 millimeters distal.
Yeah, it's not exactly
You
the
remember
same.
that? Yeah. So, you know, it's a lot to learn. I think the survivors of this type of disease are naturally selective. You know, the nature selects who survives, the ones that the
So you
lipid
believe in
core is
Darwinism here?
embolized. Yeah.
Yeah.
It's like a Darwin thing.
But you know-
The ones that not embolized, they thrombose, and in
So-
the left main, forget about it. He wouldn't make it to the hospital, yeah.
So this is like when you see aneurysms in the proximal vessel and you don't know, should you seal them, not seal them, will they distal embolize? It's hard to tell. Like a Kawasaki.
It's much easier to stent them, and then you sleep in peace.
But this part is not the stenosis. It's
I mean, if,
No, 3.58.
just to be fair, though, you have it on chronicity on angiograms. I mean, it may be obstructive and you're obstructing
not ready
it
in
because
room 2
it's
yet?
obstructive, or stenting it because it's obstructive, but not because.
Okay, now you see here, they will be ready in room 2, AK with the total occlusion. I always leave the wire in the side branch to decrease the chance of reblock obstruction. And here, all right, that ulcer is bye-bye.
Bye-bye.
Good. So now you can go other side.
Thank you.
Thank you.
Okay, Dr. Kitty.